Hi everyone. Today I'm presenting a fourth interesting case. This is a 17-year-old boy. While shoveling at home, he presented with acute onset of giddiness followed by right-sided hemiplegia. There is no positive palpitation, chest pain, rheumatic illness, fever or any other systemic symptomatology, no family history, and there is no other comorbid medical illnesses. So he was taken to nearby hospital where his MR brain and MRI brain was done, which showed diffusion restriction in the left basal ganglia and capsular region, and MR angio showed a left middle cerebral artery M1 occlusion. These are the MR and the MR angio, and since he came within the window period and he was thrombolized with tenectesis from the local hospital and sent here for further management. When he came to a hospital, his Glasgow scale was around 14/15 and he had a NA score of over 15. The clinical impression could be PF4 related or patent foramen ovale related embolic stroke or a hypercoagulable state, or other possible could be a carotid dissection with atherothromboembolism. These were the diagnosis considered initially. So he was immediately taken up for detailed subtraction angiogram and thrombectomy. You can see that there is the left middle cerebral artery stem is occluded, and we passed micro wire followed by Trevo stent, and this is followed by mechanical aspiration with penumbra, which resulted in TC3, that is 100% rate canalization with a good distal flow, and the DSN here it was 100% occluded, and we could extract a clot. This extracted clot from the M1 occluded area, which is something like a fleshy area. We couldn't identify what it was, and was sent for pathology. And the post thrombectomy CT showed a small infarct as before, the left basal ganglia as well as the capsule, no hemorrhagic transformation. This is the CCT which showed that the small infarct is still there. And next day he underwent a cardiac evaluation which showed there is a floating mass. You can see the mass which is going into the LLV from the LA and is attached here, and probably one of the a remnant, maybe a small part is embolized to the middle cerebral artery, which we could extract. This is XHS, you can see it's a straightening of the left heart border, and there is a prominent pulmonary arteries, something akin to a mitral stenosis. And this is the Doppler showed in the lying position as well as in the supine position. You can see this is the Doppler, mitral Doppler studies, and he was advised cardiothoracic surgery consultation, and he underwent thoracotomy, and he was done on pump with the excision of the tumor en masse. This is the tumor. You can see there is a tumor there, and this is the procedure, and here you can see that they remove the tumor en masse from the mitral valve, and we could extract the tumor in toto without any residue or any the valve was intact. There is no need for any mitral valve repair at this point of time, since there is no gradient, there is only very mild mitral regurgitation. So postoperatively patient was stable, echo showed a moderate MR, and there is a tricuspid regurgitation 30 mmHg. It's all fairly normal. And this is the clot. This the clot from the mitral valve. I mean from the M1 occlusion. This is the cytology, and the atrial myxoma was sent for histopathology. This shows the finding here. Okay, this the features of atrial myxoma. So patient improved very well, and there is no neurological deficit afterwards. His NS score is 0. His modified Rankin scale also 0. There is no motor or sensory or cognitive deficit. So, what is atrial myxoma? It is nothing but a non-cancerous tumor in the upper left or right side of the heart, and most often it grows on the wall and separated between the two sides of the heart. This is called atrial septum. 75% of the myxoma occur in the left atrium, then they can occur in the other intracardiac chambers as well. Primary cardiac tumors such as myxomas are rare, maybe 1 in a million, and most arise sporadically, 90%, but 10% there is one condition called a Carney syndrome. They can run in families. Then sometimes you can get tumor plop when you auscultate in the lying and the on this sitting position. You can have a tumor plop, and this would simulate a mitral diastolic murmur. And these are the various tests. They have to be done: echo, X-ray, ECG, angio, ECG, and things like that. And the management is a surgical. Complete removal of the tumor is a must. Untreated, this would lead to multiple systemic and cerebral embolization, and it can occlude the valve, causing severe mitral stenosis like presentation. And these are the various literature review causing elevated C-reactive protein and things like that. These are the various references here. Thank you very much. Bye.